I'd like to acknowledge the traditional owners of the land on which we meet today. It's a pleasure to be here at my first NDARC Symposium, but really while I'm here is to affirm the Australian Government commitment to NDARC and the work that it does, and that was demonstrated most recently by Minister Hunt extending funding for NDARC for an additional 3 years, which is fantastic to see. I'm going to move straight into my role as chairing this Families and Communities session. I'm going to call on Professor Sharon Dawe, who's going to be talking about improving outcomes for children living in families with parental substance misuse. Professor Dawe is a professor in clinical psychology at Griffith University and an adjunct professor at the Australian Centre for Child Protection. She's also a visiting fellow at Oxford University in the UK. She's been working as a researcher and clinician in the field of substance misuse and mental health for over 20 years. She's now at Griffith University and is the co-developer of the Parents Under Pressure program, working with high-risk families engaged in the child protection system. Can you welcome Professor Sharon Dawe, please?
Good morning. Thank you for your invitation. I'd like to begin by acknowledging the traditional owners of the land upon which we meet and pay my respects to elders, past, present, and emerging. Today I'm going to talk about a program that we've been involved with, Paul Harnett and I, for a number of years. And I'm going to make some links to the policy and practice implications. It's a big challenge. The families that I work with, the families that Mike Farrell and I worked with 30 years ago in the Maudsley, are really chaotic. They don't attend appointments. Their kids have lots of developmental and behavioural problems. The mums and the dads themselves have their own traumas to deal with. And along the way, we see intergenerational problems. The mums have children that are taken off them in care, and then some years later, those very children are becoming parents themselves. So what do we do in such a complex arena? And this is a problem that I've been puzzling over for 3 decades, in fact. And we've come to some general ideas. A lot of what happens is putting out fires. People are very busy solving the housing problem, solving the electricity problem, solving the attendance at daycare problem. But ultimately, what happens is that nothing really changes in the way in which the family operates. And so our greatest challenge when you've got really complex families is working out how you can actually make some change in family functioning in the context of chaos. So I grew up in the generation where we were developing a program for everything. That was the clinical psychology of the 90s. If we could only get the right manual, we would have solved problem X. CBT for depression, anxiety, child behavior problems, the list is endless. And along the way, there was a proliferation of the development of parenting programs. And by and large, these parenting programs have a good evidence base for many of the families in which they work. But when you're thinking about really complex families, who are typically excluded from randomized controlled trials, is a parenting program really the right approach? Can we really expect to start at the beginning and systematically work our way through a manual, hoping that families will come along with us on the particular journey? Can we really have a very structured approach? And then we have endless variations of Program X. So Program X for particular problems. And really, is that the best way of going? And I suppose for us working with very complex families, really where we wanted to go was to say, what are the theoretical principles that underpin a program? Can we actually identify a core set of principles and use those principles to shape and to think about how you develop a treatment program? So we have lots of manualized programs. Many of them are very good. There's the issue of evidence base. Government is very fond of evidence-based programs, but really, when you step back and think the evidence for whom, under which condition, you kind of find yourself wondering about the applicability of some of the programs that are delivered to really complex families with histories of trauma. So yes, we should have evidence-based programs, but can we really wait for the evidence? Do we need to think instead about evidence-informed programs that are guided by clear principles and theoretical underpinnings? And what does this mean for practice? Should we be trying to target families in the drug and alcohol sector? Or really should we be thinking about the presentation of complex families across a whole range of different organizations and institutions and think about how can we best intervene? I think we miss an enormous opportunity on transition to primary school. It's the point in time where parents are the most engaged in any service, in any family service other than giving birth. And yet we rarely try to target family support programs by liaising within an educational system. So the potential solution to this complex problem of trying to work out what to do with complex families is really to think about a way of developing a set of core principles that's got a theoretical rationale to it, and then, if you like, assemble a support plan that draws from a set of tools. And that's really where we've gone with our Parents Under Pressure program. We need a system for gathering descriptive information. Typically what happens when families come along to family support services or present at drug and alcohol services is an endless amount of history taking. When did you first start using? When did you first inject heroin? When did you, if it's a drug and alcohol service, if it's a family service or a pregnancy-related service, there'll be lots of questions about antenatal history. History is important. I'm not suggesting that we abandon history taking, but we need to limit our history taking and, in fact, think far more about what's currently happening in the family and thinking about a way of classifying and describing that information that captures both the strengths that are present in the family as well as the areas of challenge. So if we were to zoom out, as we sometimes say in PUP, and take a kind of bird's eye view, really, what is it that we want for the families that we work with? And we have what we call the 3 threads of the PUP program. View of self as parent. I'm a good mum. I'm a good mum because I love my kids. I'm a good mum because I give them a cuddle at night. I'm a good mum. We need to have a strong sense of self-efficacy as a parent. And for many of the families that we've worked with, that's been really eroded away. Children need to be loved, and parents need to know how to show love. Caregivers need to know how to show love. And for many of the complex families that we all work with, the capacity for showing love is really being compromised by their own histories of trauma and neglect. And so sometimes, it's about helping a parent understand how you show love, how children feel safe and nurtured. And the most important bit really for the complex families that we work with is an ability to understand and manage their own emotional state in the context of parenting specifically, but more generally. And so there we have our 3 threads of the PUP program. I'm going to play a very short video. Now, I have to emphasize this is an actual person. This mum has given me permission to show this at limited audiences. I have to be very insistent that there's no photographs taken, and I also understand that this is being filmed, but the guys are going to be stopping their filming while we play this video. Just to provide you with a little bit of context, this is a mum who has been asked to be with your child as you normally would. It's filmed at a non-government organisation, family support centre, and it's just in an ordinary kind of consulting playroom. I'm going to play the video for a couple of minutes, and then you're going to have a pause and reflect and think about what it is that you've seen in front of you. And then I'm going to talk you through an integrated theoretical framework, and we're going to have a look at some more video and think about a slightly different lens. So if we could just start maybe at minute 2, please. Okay, so it's only a couple of minutes, but actually you can gain an enormous amount of information from careful observation. And so I'm going to talk you through the integrated theoretical framework. And then I'm going to get you to look at a couple of more minutes of the video, and I want you to apply the integrated theoretical framework. So, this is where we're going to get to. But where we're going to start is here, because children's outcomes, kids being the best that they can be, is centerpiece to the PUP program. And so what we want to know at any point in time is the little person's developmental outcomes. How are they physically, cognitively, language development, whatever's appropriate for their age? How are they doing in the context of peer relationships that are appropriate for their age, social behaviors? So what are we seeing if we've got a 1-year-old? So we really, and in doing so, we also want to identify their areas of strength and their areas where there's potential challenge. So the first thing you're going to do when you see the video next is to start thinking about the developmental outcomes for this little boy who's about 2 years and 10 months. So, what is the most proximal and the most important influence on children's developmental outcome? And we now, of course, have decades and decades of research to say that it's the quality of the caregiving relationship. And so we need to understand, and we need a framework for determining what we mean by a good quality caregiving relationship. So saying that she's a nice mum, the house is clean, all seems to be fine, is not describing the quality of the caregiving relationship. What we need to know is have a framework for understanding, from a theoretical point of view, what makes for a good quality caregiving relationship. And here we draw from the emotional availability constructs that Zeynep Burijan's articulated. So we're looking for sensitivity. We're looking for a mum who responds to and understands her child's cues. I'm using the mum word for this presentation because we happen to have a mum. The same applies for a dad, a granny, a foster carer. What we're looking for in that primary caregiving relationship is sensitivity to the child's cues. And we're looking for warmth, which is not about being a play school mum and singing and dancing, but it's about a genuine attunement, warmth, and obvious enjoyment with the child. So check to see whether you're seeing that. We're looking for structuring. As a species, we cannot develop in isolation. We need to have input constantly. From the moment that we're born, we need to be held, we need to be stroked, we need to be talked to, etc. And in order to have that good developmental outcome, you need a caregiver who's structuring the environment for the child. So recently we were working with a mum who'd had several children removed. 5 years later, she had a new baby. She was terrified about this child being removed. The child was 6 months and had extremely poor motor control and could not sit without being supported. Why? Because this mum was so frightened that this baby might get hurt that at no time was the baby ever given the opportunity to not be surrounded by pillows. So there we see a failure in structuring. This child's not being given the environmental opportunity to develop as it should. So we need structuring. In order to learn language, we need to be spoken to. We need opportunities for running, moving, etc., etc. So structuring is really key. We need parents to be non-hostile. We need parents who are not intrusive, but equally as importantly, in the emotional availability system, we look to how is the child behaving, because the child speaks volumes. Do we see a child who is withdrawing from a parent? Do we see a child, and I have videos of children who look so confused when their mum's trying to play with them that they go and sit underneath the desk. It's a more comfy spot. So we're looking at child involvement, the extent to the child wants to include the parent, and we're looking at child responsiveness, the extent to which the child follows directions or responds. So that's absolutely key. And then we need to have a look at our blue circle, which starts off with parenting values and expectations. And so really one of the ways of unpacking what is your expectation is, and your values, is to say, how would you like this little boy to be at 13? He's 3 now. And in 10 years' time, what would you like his life to look like? And for a lot of the parents I work with, the first answer to that is, well, certainly not like me. And then you kind of have to drill down and unpack, well, what does that really mean? And identify some clear aspirations and articulate those values. You need disciplinary strategies, you need monitoring, and you need family routines, all of which are important, but many parenting programs place that at the forefront in the absence of looking at the quality of the caregiving relationship. And so at times, if this becomes, if this becomes your focus for your treatment strategy and you have a very hostile parent-child relationship, what you're doing really is just giving new ways to be horrid. So it's very important that you have a clear assessment in the complex families that we work with of the caregiving, quality of the caregiving. We talk next about our pink circle. What is going to impact here in our blue and our yellow circles really is mum's capacity to manage and regulate her own emotional state. Highly impulsive, dysregulated parents, parents who are very depressed, are significantly compromised in being able to engage in your blue and your yellow circle. So telling somebody who's agoraphobic and highly anxious that they need to go to a parenting group in order to acquire parenting skills is really a bit of a non-starter, obviously. But it happens. And here we have connectedness to family, to community, and to culture. And that is absolutely core to our well-being as a species. We are, after all, herd animals. And we arrive at the outer circle here, because these things matter. We can't just kind of silo things and say, oh, well, we'll send mum off to CAMHS for a depression, and then we'll send Lily off for assessment at the Child Development Service because we're a bit worried about autism. And along the way, we'll send somebody else off to sort out their electricity. It just is a mess. Families feel overwhelmed. There's too many services involved. But you can't ignore the real-life crises. So somehow what we need to do is to make sure that even though we may be working in the wider ecological context, that we're doing it with having clear understanding about how this is impacting on the quality of the caregiving and the routines and mum's well-being. And so you do it in a far more purposeful and stated way. So what I'd like to do now is just play another couple of minutes of that video. And I want you to, first of all, think about his developmental outcomes. I want you to think about his motor, his language, his social behavior, his attention and concentration, and just form some views in your own mind about this little E's outcome. And then I want you to think about the quality of the caregiving relationship and what it is that you're actually seeing. And then you're going to reflect on mum's well-being, state of mind, and you're going to look to see whether there's any evidence of routines in this family. So you've only got 4 minutes, but you'll be amazed at how much you actually see. Can we play next 4 minutes, please? Okay, I'd better pause it there. So just have a little ponder for a moment and maybe just talk to the person next to you about what you thought about developmental outcomes for this little E. What are some of the things that you could say or struck you about his outcomes? Fine motor, gross motor? Have a pause. Talk to the person next to you. Okay. What did you see about the quality of the caregiving? Sensitivity structuring, child involvement, child responsiveness, sensitivity structuring, warmth, attunement to child's cues. What did you see? Chat? And then just quickly reflect on mum's state of mind. What might you think about mum's state of mind? Yeah. So we've watched 9 minutes of video. Let me give you a little bit of a rundown if we think about what we saw, and I have seen this quite a few times, so I probably have noticed things that perhaps others haven't. But anyway, child developmental outcomes. He's got amazingly good fine motor skills. I mean, look at how he's unwrapping those sandwiches. He also has really good balance. Look at how he went up and picked up the little blue squares and circles, carefully took them off and brought them down. He's engaged, his attention and concentration is very good. He follows instructions, put it back, okay. Did we hear him chat or talk? No. There's very, very limited language, so very little expressive language. His receptive language seems possibly okay because he actually followed mum's instructions, but there's very little dialogue really there at all. So what we have is a little E who's actually got amazing attention and concentration, who's following directions, who's got very good fine motor skills. We're a bit concerned about the eye. You might have noticed that. He's still in nappies. We note that. It's okay. He's not yet 3. So in fact, there's actually an awful lot of strengths, but we would do question mark language. So what do we see in the quality of the caregiving relationship? We just don't see any warmth. You know, she's really just not attuned to this little boy. The structuring, there's the complex moments around the cup of coffee, and she just can't engage with that cup of coffee game. And so we see very poor sensitivity and very little structuring. She's not hostile. She doesn't get impatient. She's just flat. She's just not there. But think about child involvement. He keeps on coming back. He keeps on bringing her things. He went and got his lunch and brought it back to sit next to her. Everything he finds, he's working really hard, which tells us that this has not been his life forever. Because if he had been a neglected child, if he had grown up in this environment from birth, he would not be working so hard. He's wanting something different because he's had something different. And that's an enormously important part of thinking about this particular dyad. Family routines and monitoring. Somebody somewhere packed a lunch and put sandals in a pushchair, and he knew where they were. And it was okay. White bread sandwiches and something else was in there, all wrapped up in glad wrap. It was a good thing to bring to a session for, this little E. So there's some family routines and monitoring, but we all have, of course, arrived at the point where she's really depressed. So, and of course, there's lots of other wider social circumstances that we would build up when we're doing our PUP training to help understand this case. But just to provide you with a little bit of a kind of happy ending, the person who worked with this couple, she had a background in nursing. So the next point is, where's your way in? How do you engage this family? What do you do? Well, what you do is you find a way in. You find a way in where you can make a small change that's meaningful to the caregiver and that she values. So the first thing we want to do with this depressed mum is to find a snippet of video that's going to make her feel better. And the snippet of video I like is him unpacking his sandwiches, because that 20 seconds is about what a great job you did as a mum, packing his sandwiches and bringing it along, and look how good his attention and concentration is and how focused he is. So there's your little snippet of good strength stuff that'll challenge mum's view of self that she's a rotten mum. But how do we work therapeutically? The person who started this process, the first job she did was she wanted the eyes fixed. So she worked with mum, they did an action plan, they got mum, how are you going to get, what bus are you going to get, how are you going to get there, let's make the appointment together, etc., etc. She actually managed to get the little E off to have his eyes assessed. And as luck would have it, it was a lovely doctor who said, fantastic that you've come along, this is perfect time, we can solve this problem. So immediately there was a win. But there's other ways in. If I'd been working with this family, I'd have got her to start reading books and talking to him. That would have been my first goal, to actually move to 3- and 4-word utterances. Because he was right there. He was going to go there. But he had so little stimulation. So as a PUP therapist, your job is to work out what's going on in the dyad and in the wider social context, what your way in is, and there's no right or wrong way, and how you're going to get some runs on the board. So that was, and we had a good outcome with that case. That mum did really, really well. So how do we do it? Well, we've got a toolkit. We do the assessment, and then we've got a toolkit of 12 modules. And you dip in and out of those modules. Some of the modules will go for a very long period of time. They'll be the kind of main focus of your work. Other modules you might not even use at all. Okay, so I'm going to shift. Just remind me, I've got till 10? Yeah. Okay, so I'm just going to shift now to talk a little bit about some of the data that we've acquired. And this is the randomized controlled trial that we ran in Brisbane some years ago. And essentially, I'm going to just quickly run you through our key outcome measure was child abuse potential. And what's interesting about this graph here, if I can get my little thingy happening, it's hard to see. This isn't statistically different, but what you actually see is some improvement here in our 6 months post-treatment, but interestingly, the improvement continues. So, and this is not that uncommon, actually, in child and family research. You kind of see an accumulation of effect over time. So this is at 12 months. What we see here in the families attending the methadone clinic was not very good news. We had a range of other measures that, interestingly, parenting stress, depression, anxiety, parenting stress inventory and depression, anxiety, and stress showed very similar patterns. So we had some convergence, and we also saw a reduction in methadone dose in that study. So more recently, we've done a number of other studies, but I'll just share with you more recently the results from our RCT, and this is open access, so you can download it if you're interested. So this was a pragmatic trial. There were 5 sites, and the treatment was delivered by practitioners located in family support services. We had rather good retention rate for such a complex population in both arms of the study. The families were very similar to the families that we saw in our 2007 study, that we've seen in our OxPup study, and a range of other studies that we've done. So pretty complex families by and large. The children were young, much younger here than our other study. That was the goal, was to work with children from birth to 3 years of age. And many of the mothers were actually recruited in the latter stages of their pregnancy. The BCAP, Child Abuse Potential Inventory, was our primary outcome again, and here we don't see exactly the same pattern of improvement, ongoing improvement in 12-month follow-up, but we see a very similar pattern here. And although it looks like it might be getting worse, that wasn't significantly different. The big question really, of course, is where this red line goes at 2 years. So do we see a return to problematic baseline measures? What happens here with our blue line? Does it just continue to get worse? So enduring problem, the funding for these research trials doesn't extend long enough. But anyway, optimistic. We're interested in our pink circle. This was really a study that Paul and I worked on to try and tease apart that pink circle. So we had a lot of measures of parental emotional well-being. Can you really get improvements in dysregulated affect in the context of a program like PUP? So here's our DERS, difficulties in emotion regulation, which is significantly different. We looked at PAI borderline. So I'm not suggesting that we're curing borderline PD, but what we are seeing is considerable improvements in impulse control, particularly. And here's just, it's always nice. I've become really interested in qualitative research in my latter years as an academic. And here are some lovely quotes that give you a sense of what it was like for the families that took part in this study. So here, this is clearly what we would call a pink circle case. This was a mum where anxiety was really the overwhelming and driving feature of the case presentation. We use mindfulness strategies and mindful parenting as one of our core strategies for improving emotion regulation, and that was something that she noted here. This is rather a nice quote that reflects view of self as parent. So she's clearly feeling much stronger and more confident in that parenting role. And this was, we have a project in Dublin that we did an evaluation with, and this is just, you have to read this with an Irish accent. Maybe Mike could read it for us. This is work that we do with a residential treatment facility for women and children called Ashley House, and many of the women come from the travelling community and have had very significant exposure to extensive trauma, childhood trauma and adult trauma and prostitution. So it's an interesting project. Okay, so I'm just going to skip through this because it's a little bit slide heavy. You can read it. And I suppose just for the last 2 or 3 minutes, just thinking about going forward. So one of the things that we're keen on doing is working with men, because parenting programs aren't really parenting programs, they're programs for mothers. So really, if we flip the coin and say, how can we engage fathers in this process? We're having a go at doing that. That's the FASD one. We're having a go at doing that in our Pup for Dads project in Stirling, funded by NIHR. So these are dads who are currently enrolled in opioid dependence. And the focus of a lot of the work there, if we think about the principles and theoretical underpinnings, a lot of the focus is on managing aggression and hostility in the context of being a dad and in the context of being a partner. So we have very high rates of men who themselves grew up being beaten, and a kind of normative view that whacking your kids is okay in the context of dysregulated affect. So that's really a very challenging approach. We're also working a lot in the FASD field. We're developing diagnostic processes for little kids, my passion, 3 to 7-year-olds. And there, the focus of our PUP work is thinking about how do you enhance executive functioning in very young children. And we, fortunately, at the age of 4, 5, and 6, have a wonderful opportunity, because that's where you see the development of executive functions, of actually helping to support and improve that in children with FASD. So hopefully watch this space. I'll try for yet another grant. So thank you. That's a rundown of the PUP program, and I hope you've had a sense of what it's like to be a PUP practitioner. Thank you.
Thank you very much, Professor Dawe. I think we've got just a couple of minutes for questions. If people out there in the audience have them, I know we've got a couple of people at the front of the room here with microphones. Have we put you on the spot too much for the questions?
That's okay. I'm around all day.
So I'm sure Professor Dawe will be here for morning tea and lunch as well, and be more than happy to catch up and have a conversation with you about her work. Can I ask you again to thank Professor Dawe? Okay, so next on our list of speakers we have Professor Ju-Lee Oei.
Close enough.
Sorry, Oei. Okay, and so she's going to be talking to us about neonatal abstinence syndrome. So the professor is a neonatologist at the Royal Hospital for Women, conjoint professor in paediatrics at University of New South Wales, and a visiting medical officer in addiction medicine at the Murrumbidgee Local Health District. Her areas of research interest are in neonatal resuscitation and perinatal drug use. Can you welcome the professor?
Great. Thanks, David. Thank you, Michael, for inviting me. It's a real pleasure and an honor to be here. I have 2 parts to my life. One, I work in an NICU, and the other one, I work in addiction medicine. So I'd like to talk to you about NAS, Neonatal Abstinence Syndrome, and I'm sure you've all heard of that. Neonatal Abstinence Syndrome, otherwise known as neonatal withdrawal, but one of the biggest misnomers in medicine, I think, because it's not only affecting the newborn infant, and it's not only withdrawal, and I'll talk to you about why. All right, let me work this out. Okay, so the other name for neonatal abstinence syndrome, or NAS, is newborn withdrawal from maternal drugs. And what happens with a baby that's born to a mom who uses chronic drugs of addiction is that they become tolerant. So at birth, the babies, unlike you and I, can't see drugs, and the Drug supply is abruptly cut off when you cut the umbilical cord, and depending on what drugs the baby has been exposed to, they go cold turkey into acute withdrawal. Okay, so the trouble with NAS now is considered a major global public health epidemic, predominantly due to prescription drug use, and you're all familiar with the epidemiology, but in the good old USA, it's estimated that at least one baby is born with NAS every 15 minutes, leading to a 300% in the number of babies with NAS over the last 10 to 20 years. Not a big drama, but if you look at hospital costs have increased by more than 6-fold. And I think there are no cost studies in Australia, but in the US, it's about $500 million to $1 billion a year just for hospitalization care. So the trouble with NAS is for us in newborn medicine, it can kill. So it's not a new problem. It's been known for centuries, first starting off in Western literature as congenital morphinism. Men drank alcohol, women took morphine. Very accepted part of normal life in Victorian ages. So what we know about congenital morphinism was noted way back then. Normal babies are born, and within a couple of days, they started becoming unwell. And then in one tragic case, one mom had 16 babies and 15 died. And the one that survived was given a couple of doses of morphine every couple of days. So without treatment, NAS has one of the highest rates of newborn mortality in our field of medicine. 9 out of 10 babies will die. And as late as the 1950s, it was estimated that up to 30% of these babies, even though if they were found, treated early, would still die. So it's a serious condition. And why do they die? So what we know is that they're normal at birth. These babies are beautiful. They look gorgeous. But within a couple of hours, days, depending on what the moms took, they become irritable, they're restless, they shriek like they're in pain. And if you've ever seen a withdrawing baby that's untreated, it's an awful thing. So they start feeding poorly, they vomit, they have profuse diarrhea, they're inconsolable. And they have profound weight loss, and with that, electrolyte imbalances, their sodium goes off, their potassium goes crazy, and they start having seizures. Within a day, couple of weeks, maybe they're at home by then, they die. So this is the pattern if you don't find a baby that's been exposed to maternal drugs. So, but now we know that it exists, and we're very good at recognizing and treating the babies, and NAS has become a very uncommon direct cause of infant death. And most babies with NAS will survive to go home from the hospital. So what happens to them? Unfortunately, it's like looking for a needle in a haystack, because I'll tell you why. They're very hard to find. So in New South Wales alone, we think there are more than 1,000 NAS babies born every year, and those are the ones we know about, not the ones that, take a few medications on the side and don't bother to tell you because they don't think it's a problem or they don't want to tell you. So these babies are very mobile, as you know. About half of them will be placed into foster care by the time they're 5 years old. They move multiple homes, they have different names, they move multiple schools, you can't find them. Lots of social and environmental problems like Sharon spoke about. The parents don't engage with you. And what is most important for us is that the majority of them are healthy. We don't want to spend David's hard-earned dollars following up healthy children. But we need a life map. We know that problems don't stop when they leave the hospital of birth. So we're very fortunate in New South Wales that we can use a system called data linkage, which you're all familiar with because you're researchers, and we can find babies with NAS. So we used this method to look for babies with NAS a couple of years ago, very hardworking medical student, and she used birth records in New South Wales that has identifiers like your names, your date of birth, your addresses, hospital numbers, and she linked it to admission data, looking at P96.1 as the ICD-10 code. Oh my God, it doesn't work. ICD-10 code for diagnosis of an NAS baby. And she linked these babies to their death records and to school records. And what did she find? So we found almost 4,000 children with NAS, born in New South Wales from 2000 to 2011. And she compared them to about 1 million other New South Wales children. So these are the moms, the usual story. They're younger than other mothers. They're more likely to be indigenous. They smoke cigarettes, and they have no antenatal care. A lot of them have no antenatal care, and they're also socioeconomically deprived. Unfortunately, that's nothing new. But the babies were more likely to be preterm and low birth weight. And if you're a small baby, below 2.5 kilos, you need a lot of help to keep alive. You need sugar problems fixed, you need breathing problems fixed. So they all come into the nursery. Almost 3/4 of them come into the nursery compared to about 15-16% of normal children. And they stay 3 times longer, 10 days. This little pointer thingy doesn't work. 10 days. Compared to 3 days for a normal baby. So what, 10 days, you go home before 1 week of age, not a big deal. But if you look at how much a day in the nursery costs, so in our NICU, and if you don't have Medicare, you're on holiday and you drop out the baby, you come into our nursery, we charge you $6,000 a day per baby. So the best NAS baby will cost an average of your tax dollars, $60,000. Probably even more. We've had babies stay in our nursery for months to months. Okay, but what happens after they go home? And what we found from our linkage data was that these babies kept coming back into hospital, a lot more, 2 episodes compared to like 1.5 for other babies. And this risk of hospitalization continued until they were teenagers. If you look at this graph, you can see that the green line representing the NAS babies is significantly higher than the blue line representing the other children of New South Wales, and that continues on to 12 years of age. They kept coming back into hospital. And why did they come back into hospital? They were hospitalized for reasons that were not of their own cause. So they were not ill when they came in. So if you can see here, they came in for things like burns, corrosions, poisoning, maltreatment, accidents, assaults, and unfortunately my pointer doesn't work, but what was striking was that they came into hospital for these nasty things at a significantly earlier age, 4 months compared to 11 months. So what this suggests is that these babies left our hospital of birth and then were promptly brought in for these nasty things. So they were not safe when they went home. And then they were also brought in for unusual reasons. A normal child is seldom hospitalized for mental and behavioral problems unless it's really, really bad. And you can see here, they kept coming in for things like mental retardation, speech and language problems, autism, behavioral and emotional disorders, things that didn't signify them as being physically unwell, but would have major impact on their future functioning in society. And what is striking about this, opposite to the other slide I showed you, was these kids came in at the median age of 5.5 years, compared to 3.5 years for other children, suggesting again that these kids were only picked up after they went to school. And the later you find these children and you provide intervention, the less effective your treatment will be. And the other question we asked was, did these children die? So you hear news reports, infants or parents using drugs, found dead, higher mortality rate, but does this specifically affect the NAS children, which we keep in hospitals of birth for weeks and weeks to months and months, social workers everywhere, making sure that they're okay when they go home? Unfortunately, the answer is yes, at the rate of 3 times other New South Wales children. The most dangerous time for us, for everyone, to die is when you're born. So the highest mortality rate is when you're born. And what our NAS children do is that they do not die at birth because we're all over them, but they die between a month and a year of age, which suggests they die after they leave your hospital and before a year when all our well-meaning services recede from the maternity side of things. So, yeah, they die 3 times. And the risk of death continues until they're teenagers. So the red line represents the NAS babies, and as you can see, the survival rate is significantly lower than the other children of New South Wales. And why they die was usually unclear. They don't come into hospital before they die, so a normal child that dies usually dies of an illness. So if they have cancer, they have heart disease, they keep coming into hospital repeatedly, these kids just turned up dead. And they needed an autopsy more than 4 times other children because the cause of death was usually unclear. So of the reasons of why they died that we could discern from the mortality data was they died of things that were ill-defined, things like sudden infant death syndrome, and unfortunately things like accidents and assaults, maltreatment and trauma. So if they survived, what happens to them? So every child needs to go to school. If you don't do well in school, it is really bad for your outcome. You have physical problems as an adult, psychological problems, you don't earn so much, you don't adjust so well, and the school to prison pipeline is a well-defined route. So not sure whether it is an urban myth or not, but apparently in the state of Texas, they estimate how many prison beds they will need in 10 years by seeing how many kids fail by grade 3, which is 8 to 9 years of age. So how do our children with NAS do at school? We don't know, but children with NAS have multiple risks for poor learning. Could it be the direct drug effects? Could it be parenting, genetics? Could it be social? These kids usually flit from school to school, home to home. They can't settle in any way to get good learning. And is there a biological basis? Because all drugs that moms take will cross the placenta into the growing fetus. And it's very unusual for drugs to cause overt structural abnormalities to the brain, like alcohol. Alcohol is the only known structural neuroteratogen. So these are two brains. On the left is the brain of a normal 6-week infant who died of unrelated causes, and on the right is the brain of an infant of an alcoholic mom. You can see how small it is, how simple it is. Not many of the drugs that we're affected by will do things like that. But what is important is that the brain is mostly formed in the first trimester, the first 15 weeks of gestation. And most of our ladies will engage with our services after that. Average booking in time for us is 22 to 24 weeks. Boat sail, long gone. But what these drugs do is that they continue to affect the growth of the brain. So opioids, for example, will impair the myelination of your neurons, your dendritic arborization, and how your neurons live. They'll increase your neuronal death rate, they stop your neuronal growth, and indirectly, they also increase vascular contractility. So the placenta and the brain doesn't get as much oxygen. And in newborn babies, the fastest rate of brain growth is after the second trimester and into infancy. So if the baby is still exposed to drugs in utero and still being treated for NAS with medication, they are at risk of brain development. So what happens to the brains of babies in NAS? Unfortunately, we can't chop their heads open to have a look, not acceptable. But we can do other things like imaging, and we did a study where we looked at the brain MRIs of babies that were exposed to opioids. So we compared the brain, we hypothesized that these babies would have structurally normal brains, but we wanted to look at their brain volume, knowing the theoretical impact of opioids on brain volume and growth. So we looked at two groups of babies. The orange one, babies of moms who were really good and were on the methadone program, said they didn't use anything else. And in the red, babies of moms who were really off the planet, right? Very chaotic, used multiple substances, multiple opioids. And we hypothesized that the babies of moms who used only one opioid would have bigger brains, right? And in the general population, the bigger your brain is, the higher your intellect. And unfortunately, David, no, we didn't have money to do control MRIs. So if you're, yeah. All right. So, all right, what did we find? So brain volume on the left side in males, and brain of the single opioid using mothers, an orange box set, and the multiple opioid using mothers in the red box. So as you can see, the multiple opioid exposed babies had smaller brain volumes. Okay, but compared to normal babies, what was it like? Not sure whether you guys know what the normal brain volume is. So if you had a full-term baby, you would want the brain volume to be at least 450 mils. So these guys had significantly smaller brains. And this is what we find in our clinic. And we keep measuring their head circumferences like lunatics, right? And they don't seem to grow as well. And also what was interesting was that the cerebellum, the structure at the back of the brain, was very, very small. And the cerebellum controls your smooth motor coordination, your movement, but it's also increasingly recognized as being crucial in cognitive development. These guys were hit everywhere. But in real life, how did they do at school? And all of you have got kids or know of kids who have done the NAPLAN, the very maligned test. I think it's a fantastic test, but I'm Asian, right? Asian mother, right? It's compulsory for all kids in Australia. You can't escape, and they get tested in all these things from the ages of 8 to 9, year 3, and they do it every 2 years until they're 9 years old, for those of you who have gone beyond the NAPLAN stage. So it's quite a basic test aimed to identify children not meeting minimum standards, about 1 in 5 children in the population. Exemptions very uncommon unless you just landed in from a non-English speaking country, you're very sick, whatever, and New South Wales has one of the highest sitting rate, more than 95%. And this is a NAPLAN graph. You've got a score of 1,000 divided into 10 bands. And what happens is each year the child's tested, the scores should go up because they get more skills. So when you look at the NAPLAN plot over the child's lifespan, they should have higher scores with each test. And children below the minimum standards at each stage are considered not to have the skills to progress onto the next level of education. They're stuck unless they get help. So, our NAS children. We found about 500,000 of children who were eligible for the NAPLAN. The red box, about 2,000 NAS children. We compared them to socio-economically comparable controls, the purple box, and to the rest of the New South Wales population in blue. And what we found was that children with NAS were 20% more likely not to have a NAPLAN record. They could not be linked. Whether it was due to multiple name changes, whatever, we don't know. They just couldn't find them. But by year 5, almost half of them, compared to 1 in 5 of other children, failed to meet minimum standards. And what was terrible was that this graph represents their scores over 3 test levels from year 3, year 5, year 7. The bottom line are the NAS children. As you can see, they start significantly lower, but by the time they reach high school, their scores are lower than children in primary school, 2 years younger. This is devastating because that means that they can't progress onto the next level of education. But as I told you before, I've got 2 lives, right? I've got a newborn intensive care life and got a drug and addiction life. So how do children with NAS compare to our other sick children, especially people like my little friend Floyd here? This guy was born in 1998. He was 500 grams. You know, when he was born, he had like a 1 in 2 chance of walking out of our nursery alive. He lived. But you can see that he's tiny. His brain growth, development will be of major concern. And then we have little Robert, who was born in the same year. He was a full-term baby, beautiful baby. He had NAS, mom's on the methadone program, did really well. His chances of survival were fine. They were like 100%, right? Okay, 2 minutes. All right, okay. So what happened to Floyd and Robert? I actually got Floyd's NAPLAN results, so yeah. Doing too bad. Anyway, this is Floyd at 16. That was about 5 years ago now. He's a cranky little teenager, but, you know, he's gone on, volunteer trips to Vanuatu. You know, he's really good. He's gone to uni now. And what happened to Robert? Mom's died. Dad died. And we don't really know. And how would they do in the NAPLAN test? So, 3 bars again, representing 3 populations of the NAPLAN scores from year 3, 5, and 7. The top one are the New South Wales children who are born at full term, healthy children. And can anyone guess what the dark green line in the middle represents? The NAS babies or the extreme preterm babies, the ones who had the 50% chance of dying? The preterm babies, absolutely right, Professor Farrell. And the bottom line are the full-term NAS children. They are even lower than extremely preterm children, so which is very, very concerning. So to conclude, we need to, David's giving me lots of hand signals, we need to think beyond NAS. The problems do not stop with the neonatal period or with withdrawal alone. The effect of prenatal exposure to drugs is profoundly enduring and unfortunately very subtle and damaging to the child. So we really need to do a lot of further research to see how we can ameliorate the effects of maternal substance use, because we will never be able to eradicate it. Thank you.